Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are going to discuss the ovaries, which house the ever-important eggs that are needed for pregnancy. When discussing ovaries and eggs, age is probably the most important factor to discuss and consider. This is because there is a significant decline in egg quality and egg quantity with age. It occurs more quickly in the 30s, especially after age 35. With this more rapid decline in quantity and quality, there is a more significant decrease in pregnancy rates and increase in miscarriage rates. First, let's start by understanding egg quantity and the process of ovulation. An individual with eggs is born with all the eggs they will ever have, and as they age, these go down in quantity and quality. In fact, they have the most eggs they will ever have during fetal development in their mother's uterus, about 6 million eggs. At birth, they have about 1 to 2 million eggs. By puberty, they have about 300 to 400,000 eggs. And by their early 30s, they have around 100,000 eggs. Immature eggs sit deep within the ovary, and every month a group of immature eggs come to the surface of the ovary. These immature eggs sit in small sacs of fluid called follicles, and the total group is called the antral follicles. A hormone from the brain called FSH, or follicle stimulating hormone, acts on the ovary to help one of the immature eggs grow and mature. As this happens, the follicle the egg is housed in also grows. Eventually, the mature follicle sends a signal to the brain to produce a different hormone called LH, or luteinizing hormone, and that triggers ovulation. The mature follicle then releases the egg. This process of ovulation releases or uses up a single egg each month. This means that over a lifetime, only a few hundred eggs are ovulated. So it doesn't explain the significant decline in egg quantity we see over a lifetime. That occurs because many eggs are lost each month, not just the one that matures and ovulates. Firstly, because the remaining immature eggs in the antral follicle group will die off, a process called atresia. But secondly, many other immature eggs sitting deep within the ovary also die off every month. In fact, every month there is a loss of about 1,000 immature eggs. Egg quantity, also known as ovarian reserve, is assessed using a group of tests called ovarian reserve tests. These include 3 key tests. 1, a day 3 FSH level. 2, a day 3 antral follicle count. And 3, an AMH level. A day 3 FSH, or follicle stimulating hormone level, is a hormone measured in the blood. FSH is the hormone that comes from the brain and signals the ovary to grow and mature an egg. FSH levels measured early in the cycle, usually tested between day 2 and 4 of the cycle, should be low, so less than 10. High levels of FSH reflect lower egg quantity, or ovarian reserve, because it means that the brain is working harder and releasing extra FSH to get the ovary to respond and mature an egg for ovulation. A day 3 antral follicle count is an ultrasound assessment of the ovaries. The number of immature eggs that come from deep within the ovary to the surface of the ovary every cycle are counted by measuring the number of small antral follicles sitting on the surface of the ovary early in the cycle, usually day 2 to 4. How many eggs come to the surface of the ovary at the start of a cycle is generally a reflection of how many eggs are within the ovary. meaning if a good number come to the surface, we assume there is a good number of eggs in reserve. An AMH, or anti-Müllerian hormone level, is another hormone measured in the blood. It does not have to be tested early in the cycle, as with FSH. It is fairly stable throughout the cycle. This hormone is produced by the follicles housing the immature eggs in the ovaries. So the more AMH in the blood, the more eggs in the ovary. One important point to mention about AMH level is to be aware of the units that it is reported in. In Canada, AMH is reported in picomoles per liter, whereas American labs report it in nanograms per milliliter. Many online sources report AMH in American units, so people should use caution when trying to interpret their own results. A conversion factor of 0.14 can be used to convert picomoles per liter to nanograms per milliliter, and a conversion factor of 7.14 can be used to convert nanograms per milliliter to picomoles per liter. It's very important to understand what these tests do and do not tell you. While ovarian reserve testing can be very helpful for discussions of family planning goals and treatment planning and prognosis, they also have limitations. Ovarian reserve tests do not tell you if you are fertile or not and whether you can conceive naturally. They also don't tell you exactly how many eggs you have or exactly how long you have before your fertility is significantly compromised. And finally, they do not tell you about your egg quality. These tests give you a sense of your egg quantity, meaning they tell you whether your egg quantity is average, above average, or below average for your age. They also give a sense of how you will respond to fertility medications that are used to stimulate the ovaries in an IVF or egg freezing cycle. Now that we have covered ovarian reserve or egg quantity, let's understand egg quality. Egg quality refers to whether or not an egg has a normal number of chromosomes. Chromosomes are DNA molecules that hold your genes, all of the genetic information for your body. The correct number of chromosomes in a human embryo are 23 pairs, so a total of 46 chromosomes. One chromosome in each pair comes from the egg, and one chromosome in each pair comes from the sperm. So a chromosomally normal egg has 23 chromosomes. A chromosomally normal embryo is referred to as euploid. A chromosomally abnormal embryo is called aneuploid. Age is the main factor that affects egg quality. As an individual with ovaries ages, the number of eggs with an abnormal number of chromosomes increases. These eggs either have too few or too many chromosomes and often result in no fertilization. If fertilization does occur, they lead to the development of aneuploid embryos, which may result in no implantation or a miscarriage. It may also result in a live birth of a baby with a chromosomal disorder. In addition to age, other factors that may affect egg quality include 1. Lifestyle factors, such as smoking or recreational drug use, such as marijuana. 2. Environmental factors, such as exposure to plastics, specifically the chemical bisphenol A, or BPA. 3. Medical conditions, such as endometriosis. And 4. Medical treatments, such as chemotherapy or radiation treatment. Currently, there are no specific tests to predict or test egg quality. Age is the best indicator of egg quality that we have right now. Age, combined with a review of lifestyle and medical history, will help predict egg quality issues. Although age and some of these factors, like previous medical treatments, can't be changed, some factors, like lifestyle factors, can be modified to help improve egg quality or at least slow the decline in egg quality. Now let's take some time to review some common questions that I hear about ovaries and eggs, because I think it really helps to understand some of the details around egg quality and egg quantity. The first question I hear quite often, especially when discussing IVF treatments, is, will I run out of eggs faster if I do fertility treatment? Or asked another way, will I go through menopause faster if I do fertility treatment like IVF? The short answer to this is no. But let's understand this a bit more, since it's such a common question and one that really worries people. In a natural cycle, a group of immature eggs come up to the surface of the ovary at the start of the cycle. Then, FSH from the brain acts on the ovary to grow and mature a single egg from this group. The remaining immature eggs die off, unused. Fertility treatment in people that ovulate regularly is based on trying to stimulate the ovaries to mature more than one egg from the group of immature eggs that come to the surface of the ovary at the start of the cycle. So making use of eggs that would otherwise have died off and never been used, rather than using up extra eggs from an individual's total egg reserve. I also hear quite a few questions and concerns around the birth control pill. The first one is, do I have to go off the birth control pill before doing any fertility testing or treatment? I would say that any form of combined hormonal contraception, be it the pill, the patch, or the ring, may affect ovarian reserve results. Combined hormonal contraception means there is both estrogen and progesterone present. It's important to come off a few months before completing ovarian reserve testing. Generally, 2 to 3 months should be enough to see accurate results. These combined contraceptives suppress FSH and can make the FSH look falsely low or good when it may not be. They've also been shown to lower the AMH level. Additionally, they suppress the ovary and make the antral follicle count look lower than it is. Another question, which I hear in the office, but also quite a bit on social media, is, can birth control, including the pill and IUD, cause infertility? What if you have been on some form of birth control pill for over 10 years? Does that make a difference? The birth control pill, patch, or ring does not negatively affect your fertility, and neither does an IUD. I think it's important to understand that age is a big factor in some of these cases, where people took birth control for 10 plus years. You are now 10 years older, and that effect of time on your egg quantity and egg quality is going to have a big impact on pregnancy rates and your miscarriage rates. Questions around AMH levels, specifically low AMH levels, are another common question I get asked. For example, I did ovarian reserve testing and have low AMH levels. Does this mean I am infertile? This does not mean you are infertile. It means you have a lower egg reserve. So there may be some urgency to conceive or preserve your fertility, given that you have fewer eggs in reserve. But more importantly, it means that we would expect fewer eggs in an IVF or egg freezing cycle, affecting your overall prognosis from a treatment cycle. That said, AMH does not reflect your egg quality. So you may have a low AMH, but be young and thus have good egg quality and a good prognosis for pregnancy. The last question is more of a misconception than question per se. It is around age and its impact on fertility. Over the years, I have heard from patients that thought that age doesn't really matter and that IVF can fix all fertility issues. To this, I would say age does matter a lot for individuals born with ovaries and eggs. Even if you look and feel young and you lead a healthy lifestyle with a good diet and regular exercise, age still has a significant impact on your ovaries and your egg quantity and quality. Although fertility treatments, including in vitro fertilization, have come a long way and are great at treating various causes of infertility and improving pregnancy rates, they cannot solve every single issue every time. One key example is the growing number of women in their late 40s and early 50s having babies. The public is often led to believe that IVF is what helped them have a baby at their age, but the real solution was an egg donor to overcome the impact of age on egg quality. So there you have it, all about the ovaries and the eggs, specifically the importance of egg quantity and egg quality, and the decline we see in both of these with age. Remember, egg quantity goes down with age, especially after 35 years of age. And egg quality is most affected by age, although environment, lifestyle, medical conditions, and medical treatments may also play a role. I hope this episode was useful in allowing you to better understand ovarian reserve and the tests we can do to assess this, and egg quality and the impact of age and other factors. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.